evening. Welcome to Trinity Health IHA Medical Group Wednesday Wellness, and thanks for joining us this evening. I see some people are still rolling in, so I'm just going to do a little bit of housekeeping, and then we will get going with our presentation. So video and sound are turned off for all participants, so we can't see or hear any of the attendees. Our presenter tonight will answer questions at the end of her presentation. If you'd like to ask a question, please type it into the Q&A feature anytime during the presentation. You'll find it located at the bottom of your Zoom window, and it will be the double speech bubbles with the Q&A. Please do not type in the chat feature or your questions anyway, because we may not see them. In the coming days, you will receive an email with a recording of tonight's presentation, as well as the slides presented. Any resources discussed tonight will also be included in the email. So tonight's presentation is titled Newborn Care and Lactation, Supporting Your Breastfeeding Journey. Dr. Nash, are you ready?
Yeah.
Okay.
Hi, everyone.
So this is our presenting physician, Dr. Rachel Nash, a board-certified pediatrician, and she works with patients at the Schoolcraft campus practice. Her clinical interests include newborn care, breastfeeding, adolescent care, and developmental disabilities. So welcome, Dr. Nash.
Thank you. Thanks for having me. And I'm excited to talk with all of you guys tonight. So as she said, my name is Rachel Nash, and in addition to doing general pediatrics, I am a certified lactation consultant. And so I do lactation care for our patients in the office as well. So I hope that this presentation can be something valuable to you, no matter where you're at in terms of your breastfeeding journey, if you're going through pregnancy or have a young one at home, or if this is just a refresher for you. So hopefully everyone can learn something today. So let's get started. So just kind of some objectives for today and goals for the presentation. I'm just going to go over some basic newborn care from birth to the first 2 months of life. Talk about different infant feeding methods, including breastfeeding and the decision to breastfeed. Go over common breastfeeding pitfalls and barriers, things that are commonly run into for new parents. I'll also talk a little bit about the updated AAP or American Academy of Pediatrics policy on breastfeeding. And hopefully by the end of this, help you and your family feel empowered in whatever your feeding journey is going to be. So just so you guys know, this is a general overview, and everyone's family and their journey is going to be different. So we just want to make sure that we at IHA and Trinity Health are supportive of your breastfeeding goals, if that's something that you're hoping to do. So it's really exciting. August is National Breastfeeding Month. And so this comes at the perfect time. So World Breastfeeding Week was actually the first week of August. And then in Michigan, it's actually Black Breastfeeding Week starting next week. So supporting our mothers of color in breastfeeding is super important. And so hopefully you can all celebrate with us. So I also just want to say something real quick. So, when we're asking questions and everything at the end, I just want to make sure that everyone on this presentation feels like this is a safe space. Everyone's journey is different. There are some people who will have trouble with breastfeeding. There are many reasons why people choose to breastfeed, or others choose to use formula or a mix of both. And so all of these methods are adequate nourishment for babies. And even though breastfeeding is natural, it is definitely not easy. And this is something that I tell to all of my patients that I'm working with in lactation. So I just want to make sure that everyone's aware that we want to respect everyone's journey and hopefully be able to help everyone with their questions. So we're going to start by talking about preparing for your newborn. So this is, for those of you who are in the process of getting ready, maybe early in pregnancy or later in pregnancy, but just some things to think about when getting ready. So we're going to go over some of the essentials, or some of the things that as a pediatrician, I want you to think about having in place before a baby comes. We'll talk a little bit about car seat installation, planning for safe sleep. In terms of ordering a breast pump ahead of time, most insurance companies will cover the cost of a breast pump. And so this is something that you can actually look into before baby comes to find out if your insurance company will cover it or kind of what that process is. And then it's also helpful to start thinking about adding baby to your health insurance before they come. Now, you technically can't add them until after they're born, and this can take sometimes a month or two to get them onto their health insurance. But this is something that we often give a little bit of grace period in the beginning and help you guys through that process. And then the other thing you can start to think about is finding a pediatrician. So a lot of all of our offices at IHA here, we offer Meet the Doc. So times when you can talk to the physicians and meet them in the group. There's also different ways that you can kind of reach out to pediatrician offices and see if they're accepting new patients. So these are all kind of things that are good to start thinking about before the baby comes. And I also just want to let you guys know that mothers who are enrolled in the WIC program may qualify for a breast pump as well. So you can reach out to the WIC program as well to get you set up with a breast pump. So you're going to get lots of things at your baby showers and from people, and a lot of these things will be helpful. They may not be helpful right away when you bring a newborn home, and that's okay. Some of the things that I would consider essential, or things that you definitely want to have in place before baby's born, an infant car seat or a convertible car seat, a car seat that can go from being an infant to a larger child car seat. This is super important. You're going to want to make sure that this is installed before baby comes, and that you bring this to the hospital with you to take baby home in. A stroller, a bassinet or a pack and play, some place where the baby can sleep in their own sleep environment. Diapers and wipes, lots of those. Swaddles are super important in the beginning. Blankets that you can swaddle the baby in so they feel nice and tight and secure. Making sure you have a gentle laundry detergent and washing baby's clothes ahead of time. So these are things like draft laundry detergent or free and clear detergents, something that are hypoallergenic, fragrance free, dye free, and you want to avoid having laundry pods in the home. And then a rectal thermometer is a good thing to buy. This is how we would recommend checking baby's temperature in the beginning. So this is something good to have on hand before baby comes. So in terms of car seats, there are a lot that goes into car seats, and I'm definitely not a car seat expert, but I'll kind of walk you through some of the basics and point you in the right direction with how to get a hold of an expert. So in terms of infant car seats, you want to make sure that you have a properly fitted 5-point harness. So that has the chest clip in the middle. And for babies, you want to make sure that it's installed rear facing or facing the back of the car. We want babies and children to be rear facing for at least 2 years old, or depending on the individual car seat, this can even be a lot later. So it depends on the weight and height of the child and the individual car seat. It's really the safest position of their head and neck for them to be in if you were to ever be in a car accident. And just because babies are really flexible, we want to keep their head and neck in the safest position, and that's rear facing. So we do recommend installing it that way. I would follow the manufacturer's instructions as closely as you can, and then look at the labels on the side of the car seat as well. There's 2 different kind of ways to install an infant car seat. So there's the latch, which stands for lower anchor and tethers for children, or you can use the seat belt. So the one difference is that you with latch, there is a weight limit for specific car seats. So you want to make sure that you look at that on your car seat. And then you never want to use latch and seat belt together. Even though it seems counterintuitive that it would be extra protection, you actually just want to make sure you're using one of those or the other. All car seats do meet the government crash testing, so it's important that you find a seat that really works with you and your family and your vehicle. And that's really the most important thing. And then also knowing the history of your car seat is important. So we usually would recommend buying a car seat new, but if you're not able to do that, making sure you know if the car seat has been in any accidents before, then it shouldn't be used. If there's any, if it's expired, if you can believe it, car seats expire, or if there's any recalls on the car seat, it's important to know these things before you put baby in the car seat. And then There are also places that you can go after you install your car seat to make sure that the car seat is set up correctly. You want to make sure you're looking for someone who's a certified child passenger safety technician. So this is actually additional training that someone gets. We used to say just go to the local fire department or police department. And there are some that will still check the car seats for you, but you would want to call ahead because a lot of them are no longer kind of fully trained in this. And then there's also a program here in Michigan through the University of Michigan called Mott Buckle Up, where you can schedule an appointment and they'll go through their car seat and everything and make sure everything's installed correctly. And then for more information on kind of just checking your car seat, Safe Kids USA is a great website to kind of check some of these things out as well. And the other thing is just to register your car seat once it's installed, just to make sure that you're staying up to date on any recalls or safety things for your baby. So this is just a picture of an infant car seat. So as you can see, the chest clip here, that goes across at the nipple level of the baby. You want to make sure it's nice and tight. We often say to do the pinch test above the chest clip to see you shouldn't really have any slack on that harness strap there. And then as you can see on the back, these are the lower anchor attachments that we talked about, or the latch. So this is just an example to show you guys all the different parts and how complicated it is. So something good to look at before the baby gets here. Now, in terms of feeding, some of the essentials that we think about, so obviously bottles and nipples. People ask me all the time, really, there's no right or wrong bottle or nipple. There are different types of flows in nipple. Oftentimes you'll find a little number on the inside of the nipple itself. Usually with newborns, I say to start with a slow flow nipple or a preemie nipple, just because this slows down the flow that it comes out to, and it's actually more similar to breastfeeding. So that's something that you can look into. You want to make sure that your bottles, they can be plastic or glass, but you want to just check and make sure they're BPA free or chemical free. Having a bottle drying rack can be helpful. We already talked about getting your breast pump. Usually in the beginning, as a lactation consultant, I recommend a hospital grade electric pump to start off, just because, and these are the ones that actually plug into the wall. The suction in on these types of pumps are a little bit stronger and are helpful when you're trying to get your milk supply to come in. Later on the line, when your milk supply is in and you're going back to work, having a hands-free or a cordless pump is definitely an option for a lot of moms. But in the beginning, I typically recommend a hospital grade pump. And there's many different brands. The most common ones are Spectra, Medela, but there's also a lot of other brands out there now too. You also want to start to think about if you're going to be planning to store your milk, what kind of system are you going to use? There's different bags and storage tools. Having things like nursing pads, nipple cream, nursing pillows, all of kind of those essential things that you want to think about when you are going to be feeding your baby. And then if you are planning to do adoption or surrogacy and you may want to induce lactation, that's something that you want to think about ahead of time. And you may need to start pumping in advance of the baby coming. And that's kind of a unique situation, but I do just want to say that if that's something that you're hoping to do, meeting with a lactation consultant can be really helpful. So the decision to breastfeed is a big one, and there are lots of considerations, things to think about ahead of time. You want to make sure you're making an informed decision and doing what will work best for your family. Obviously, as a pediatrician and a lactation consultant, I know there's lots of benefits to breastfeeding, but sometimes it's not the right choice for your family, and that's okay. So some things to think about ahead of time, any underlying health conditions for the mom or for the baby. If the baby is born prematurely, that can certainly affect different elements of breastfeeding. Any surgeries that moms had in the past, whether it be breast reduction or breast augmentation, that can sometimes make breastfeeding a little bit more difficult, but not impossible. How much time you have off for maternity leave, how much time your partner has off for their leave, the support systems that you have in place, your own personal beliefs about breastfeeding, other children in the home, and prior experiences with breastfeeding. All of these things come into consideration when you're making the decision, and it is definitely a big decision. There have been studies though that show that, the prenatal breastfeeding intention, or when you're pregnant saying that you would like to breastfeed, is actually closely related to actually what happens after baby's born. So this is a good thing to think about when you're pregnant and you're trying to decide what your next step is. So let me just stop my alarm here. So in terms of breastfeeding, I just wanted to kind of talk a little bit about the statistics. So breastfeeding has actually become more common in the United States. So now the most up-to-date data, more than 80% of women actually initiate breastfeeding, so start breastfeeding after birth. However, there's quite a big drop off, as you would expect. So exclusive breastfeeding, so this means only breastfeeding, not doing any supplementary formula, through 3 months is actually only about 46%. And then when you look at 6 months, it drops even lower to about 25%. So there's definitely a big, drop off in terms of, providing support for moms in those early few months with breastfeeding. And then the other thing I like to point out is this graph kind of looks at different groups in terms of breastfeeding. And as you can see, there's a pretty large disparity between non-Hispanic Black women and women of other races and ethnicities in terms of breastfeeding rates. And so this is definitely an area of improvement for us and something we can focus our support and interventions on, but I just always like to point that out. And there's also similar disparities that exist among socioeconomic lines, younger women and those with less than a high school education or less. So what are some of the benefits of breastfeeding? So there's lots of wonderful benefits, both for mom and baby. So there's lots of immunology benefits, so protection against different infections. There's been lots and lots of studies that show that babies who are breastfed have decreased rates of lower respiratory infections. So things like, pneumonia, severe diarrhea, otitis media, which is ear infections, and then even obesity later on in life. There's even been some studies that show that there might be a reduced risk of inflammatory bowel disease, leukemia, diabetes, like type 1 diabetes, asthma, eczema, lots of different disorders. So breastfeeding can really be protective against a lot of these diseases. And then for mom, there's also a lot of benefits. So there's decreased postpartum bleeding. So it helps mom heal up a little bit faster after, just because of the hormonal changes that happen with breastfeeding. And then there is decreasing rates of type 2 diabetes in mothers, hypertension, breast cancer, and ovarian cancer in those who breastfeed. There's also the element of bonding between the child and baby. Not that this cannot occur with bottle feeding, but there's definitely an element of bonding between the child. And then it's free. So, there's no cost to breastfeeding. It's, definitely easier to breastfeed right now in a formula shortage as well. So, so that's definitely a benefit. And there's no prep time. You can feed anywhere that you need to. There's also challenges though. So some babies do need specialized formulas. This is rare, but there's some babies that have an allergy to milk protein and are not able to digest the milk protein from mom. So mom may need to either change her diet, or sometimes we use special formulas in these cases. Breastfeeding can cause some physical discomfort. Now, I'll talk about this several times today, but breastfeeding should not hurt. But there can be times where you're sore nipples or you have engorgement, and there can definitely be, these can be real things for moms. And then, feeding it culturally and socially may not be something that you feel like you have a lot of support for. And then when going back to work, exclusive breastfeeding can definitely be difficult. And there are some babies that can actually not really want to take a bottle, and this can be really challenging for moms when they go back to work. There can be supply issues, either oversupply or undersupply, and this can affect your breastfeeding journey. And then sometimes when you are breastfeeding, your partner's not able to help as much. So a lot of the burden often feels like it's falling on the parent who is breastfeeding. So there is a lot of different challenges and benefits to breastfeeding, and these are all things that you want to think about when you're making the decision. In terms of true contraindications or reasons why we would not want you to breastfeed, there are a few rare kind of metabolic disorders. Two of them are galactosemia and PKU, where the baby cannot breastfeed and or must receive a special formula in addition to breastfeeding. HIV infection in the US is a contraindication to breastfeeding, although this is different in other countries around the world, but that's the recommendation in the United States. Substances such as opioids, cocaine, and PCP, these can be contraindications to breastfeeding. And then in terms of THC and or marijuana CBD use, the data is still pretty insufficient in this area, but in general, we recommend it against breastfeeding if you're currently using THC. This can be stored in the baby's fat and it can be released over time, and it can cause them to be more sedated or other side effects. And so in general, we don't recommend this. And then if you are on other medications, it's always really important to talk to your own doctor and to see if these medications are okay to breastfeed on, or if there's alternatives to breastfeed. But a good resource is called LactMed, and this is a database of all medicines and kind of the safety data behind these. So this is something I look at a lot, but it's also something that's publicly available. So in terms of reasons why women stop breastfeeding, so there are lots, there are many, but some of the biggest ones in the data are concerns about your milk quality or quantity. You know, that's something I hear all the time. I'm not sure my baby's getting enough. I'm not, you know, I don't really know how to assess that. I'm not sure that, you know, the latch is good, all of those things. So concern about milk quality and quantity, and then concerns about the latch are some of the main ones. Feeding problems in the first week can really deter a lot of moms from wanting to continue breastfeeding. So this is really a time when if this is something that you desire to do, that you do ask for a lot of support, that you reach out if lactation is available in the office where you're at, that you take advantage of those opportunities for additional education and support, that you get help in the hospital if this is something that you want to do. So that first week is really critical in terms of building mom's confidence to be able to breastfeed. And then there's just, you know, not a lot of great information out there. So hopefully today you live with some information that that's helpful for you as well. So now what to expect after the baby is born. So this is the exciting time. So baby is born, and we're going to talk a little bit about what happens in the hospital. So immediately after birth, one of the most important things that we think about, and this is all part of what we call the Baby Friendly Hospital Initiative. So these are hospitals that are supportive of breastfeeding, and they actually go through 10 different steps to qualify to be a baby-friendly hospital. And St. Joe's in Ann Arbor is qualified as a baby-friendly hospital. So that's really exciting. But one of the most important things that you can do early on is skin to skin, especially in the first hour of life. Now, I recognize I've been in plenty of deliveries myself. I know that this is not always possible to do skin to skin for various reasons related to baby or mom, but whenever possible, we want to encourage that skin to skin as soon as we can. So after baby's born, drying them off and putting them on the chest in the beginning can really help with establishing breastfeeding early on. They'll also get some vitals done, and a lot of times the nurses can do this while baby's doing skin to skin. They may get their vitamin K and eye ointment, which we'll talk about a little bit later. It's really important to try and keep baby warm in the beginning. Newborns are not the best at temperature regulation, so sometimes we do need to take them to the warmer and warm them up, but there's also a lot of temperature regulation that happens when baby's on the breast, and there's been studies that show that mom's chest and skin can change temperatures to keep baby's temperature regulated. So that skin to skin time is really important. And then hopefully within the first couple of hours that you start to initiate breastfeeding. So actually there's really interesting studies where they looked at babies after birth, and they actually go through this transition period where they'll kind of naturally climb up on the chest, search for the nipple, and hopefully within the first couple hours self-attach. Now, this doesn't always happen. And so, you know, there may need to be some supports in place, and the nurses in the hospital are really helpful. But this is a good time to start learning about baby's cues, signs that they're hungry, and to hopefully get them latched on within the first couple hours of life. So we already talked about skin to skin, but I also want to mention that in the hospital, you want to do skin to skin as much as you can. And also other partners can do skin to skin. So this doesn't just have to be the breastfeeding mom. Dads can do skin to skin, or other partners in the relationship can definitely do skin to skin with the baby. And this is all good for baby. We do recommend rooming in as much as possible. So this basically means keeping mom and baby or the dyad together. So, in previous times we used to separate baby and they were in their own nursery and they were only with mom for feeds and things like that. But we try to keep them together as much as possible. For a lot of reasons, but so you can start to learn baby's cues and do lots of skin to skin and all of that. So that's something that we really push for. In the beginning, you'll start to get colostrum. So colostrum is what you might have heard of as liquid gold. So this is the early first breast milk that comes in. It's different. It's really deep gold or yellow in color, and it's a little bit thicker than mature milk. And so this is full of really good things, lots of antibodies and nutrients for baby, things that help their digestive system develop. This really is liquid gold. And so even if you're not planning to breastfeed long-term, having baby exposed to colostrum has a lot of benefits. And this is something that I would encourage any mom to do. And lactation consultants in the hospital can help you with this. And then usually the milk starts to come in or transition to mature milk, usually around day 3 to 5. And this is when a lot of moms will start to feel engorged or start to feel their milk come in. And then, lactation consultants are your friends. So the nurses in the mother baby units have lots of experience and they can definitely help. But if you're struggling, definitely getting the lactation consultants involved early, to ensure that the baby is latching on well. And here you can see a picture of a baby latching. So some of the things we're looking at are this really wide open latch, listening for sucks and swallows, lots of different things that we're looking at as a lactation consultant and adjustments that we can make to help it be a better experience for you. And this is important in the beginning also because, if baby doesn't have a good latch in the beginning, it can lead to a lot of soreness and cracked nipples and, issues early on, which make it hard to continue breastfeeding. So definitely utilize these as a resource. Now, I just want to talk briefly about kind of the anatomy and physiology of breastfeeding, just to kind of walk you through it. So in terms of the anatomy of the breast tissue, so you have lots of muscle, connective tissue, and fat that surrounds the breast. And then these milk ducts we call these little alveoli. These are full of milk producing cells. So the milk is actually produced in these little pockets or little grapes, and then it's excreted into the middle and then goes through the ducts and out to the nipple. Now the alveoli, there's many of them, and these tissues grow over the course of actually pregnancy. And so this is what's changing and growing inside of mom during pregnancy, and she's exposed to different hormones. Now the average nipple has about 9 ducts passing through it, and then these branch into the different tissue. And then the areola is the area around the nipple, the colored part. This actually has special glands that produce oils that actually protect the nipple during feeding. And they also produce a mom's individual scent, which can help draw the baby to mom's nipple after they're born. Now, there's 2 main hormones that kind of guide the production and the release of breast milk. So prolactin is usually the hormone that increases during pregnancy. It helps stimulate the growth of the breast tissue, but it's not really at work because estrogen and progesterone, which are very high during pregnancy, those are blocking the prolactin. So the tissue is being built up, but mom is not actually lactating usually at this point. Now, after baby's born, estrogen and progesterone drop a lot, and then prolactin is at work. So mom's milk starts to be produced in the breast tissue. And then oxytocin is the other hormone that's released from the brain. And this actually helps with the letdown reflex or milk ejection. So milk actually collecting and coming through the ducts outside. And this can happen in response to emotions, to the smell of the baby. This is when you see moms having let down when they're not even trying to. This is because oxytocin is responsive to lots of different things, not just the baby sucking at the breast. And oxytocin can also be inhibited by stress. So when if mom doesn't have good support, or if she's feeling stressed, oxytocin can actually be inhibited and you may not get that milk let down. So it's a complicated system, but I just want to kind of give you guys a little bit of the basics so you understand what's happening with breastfeeding. Now, in terms of kind of in the hospital, learning hunger cues. So there's lots of different things that babies do. And in the beginning, you're trying to figure out what everything means. But I find this picture kind of helpful because it goes through the different levels of hunger cues. So it's important to start to recognize the early hunger cues, because the earlier you can recognize that baby's hungry and ready to eat, the better they're going to latch, and they're not going to be as stressed out or as worked up, which can make it hard for them to latch on. So early hunger cues might just be some subtle stirring, opening their mouth, doing what we call rooting. So if you rub their cheek, do they turn towards your cheek? Do they open their mouth? These are all signs that baby's looking for the nipple and wants to feed. Some other hunger signs that might come a little bit later, if the baby's really moving around more, stretching, or putting their hand in their mouth, sucking on their hand. These are signs that baby's definitely starting to get pretty hungry. And then if you get to the point where baby's like really crying, agitated, turning red in the face, these are signs that baby is really hungry. And at this time, it may be hard for baby to latch. So sometimes we do like a syringe feed or give them a little bit, either through hand expression or a bottle, just enough to calm them down so that we can get them onto the breast in a way that is successful. So these are kind of some of the things that you want to start to get attuned to with your new baby. Now, one of the other things that is, I think, a really important skill to learn, and a lot of people kind of skip over this, is hand expression. So expressing milk by hand can be really helpful in the beginning in terms of getting the colostrum out. It can also be helpful in emergency situations where you may not have electricity and may not be able to use your pump, or you might be in a place where you're engorged and you need to get that pressure off of your breast. So learning how to hand express is something that I definitely recommend working on in the hospital. This kind of walks you through the different steps. So, you start by making a C with your thumb and your fingers about an inch back from your nipple around the areola. And then you push back against the chest wall and then bring the nipple together to express the milk. And then you repeat this kind of in a rhythmic pattern. And so this is just something you can practice even before baby is born, just to kind of get used to that feeling. So the other things we think about, there's lots of things going on with baby in the hospital when they're there, in addition to feeding. So they get their vitamin K, which is really important for preventing bleeding in babies. They get their erythromycin ointment, which goes on their eyes to prevent infection after they're born. They get a hearing screen, they get a heart screen to make sure they don't have any congenital heart defects. They'll get a little heel poke that gets sent to the state lab and test for a variety of different disorders in Michigan. We'll monitor bilirubin or jaundice levels, which is something that we'll talk about a little bit later. We'll also keep a close eye on how much they're peeing and pooping in the hospital. The circumcision typically happens in the hospital if desired by the family, but it is important to note that we do require vitamin K before they can be circumcised due to the risk for bleeding. And then most babies will get their hepatitis B in the hospital, and you'll call to schedule your first appointment with your pediatrician while you're there. So lots of things happening in that brief period of time, but these are all just things that are important to check on baby. For some babies also, we do what we call a car seat test. So this is something we may do if a baby is low birth weight, or if they're very small or premature. And this basically involves the baby sitting in the car seat for a period of time and monitoring their oxygen levels to ensure that they can safely go home in a car seat, or if any modifications need to be made. So that might be something else that happens in the hospital as well. And then typically at St. Joe's and St. Mary's, where we usually see babies, but at a lot of hospitals now, there's actually dedicated pediatric hospitalists that will round and see the babies in the hospital. So it's generally not your PCP or your general pediatrician. They'll usually see you in the office once baby's discharged, but there's usually a dedicated team of hospitalists and nurse practitioners that will see the babies in the hospital. So in terms of alternative feeding, so sometimes in the beginning, it can be really hard to establish breastfeeding. Milk may not be coming in very quickly. And there's actually studies that show about 19% of breastfed infants receive some form of supplementation in the hospital. So it's important to keep an open mind because there may be other reasons why alternative feeding might be needed. So donor milk is a great option. A lot of our hospitals carry donor milk. This is milk that has been donated through a milk bank and screened for different diseases, pasteurized, so it's safe. And this can be used so babies can get the benefit of breastfeeding, even if mom is not able to produce breast milk. It's really important that you go through a dedicated milk bank if this is something that you're wanting to do after going home from the hospital. It can be really unsafe to buy breast milk through the internet or through other means that aren't, screened in the same way. Infant formula is obviously another option for, supplementing if needed. In NICU babies, sometimes we need to feed through a feeding tube. So either an NG tube through the nose or an OG tube through the mouth. But we do even recommend breastfeeding as much as possible in NICU babies because there actually can be really good benefits to them as well in terms of preventing serious infections and things like necrotizing enterocolitis, which is inflammation of the GI system. So breast milk has a lot of good benefits, even for NICU babies. And we want to support those all in terms of starting to pump right away. So some reasons why alternatives might be needed. So jaundice is a big one. So breastfeeding jaundice or baby not really getting enough in the beginning. That can be a reason that we may require a little bit of supplementation. Low blood sugars, especially in babies who are either large or small, or mom has diabetes, gestational diabetes. Blood sugar issues can be an issue and that can be dangerous. So there are times where we need to supplement in those cases. And then, if there's just difficulty with the latch in the beginning and we're struggling a little bit, there are times where we may need to supplement a little bit in the hospital. But our goal is to do whatever it is that you want in the safest way for baby. So we'll go back one slide. So now we're going to talk a little bit about actually going home with baby. So what that involves, and we'll kind of go from there. So one of the biggest things that I always talk with my families about a lot is safe sleep. And so this is something I just want to make sure that, that we touch on. So the ABCs of safe sleep, we really want babies to be alone in their own sleep environment, on their back, and in their crib or bassinet. We want to make sure that the sleep environment, all that's in there is a firm flat mattress and a fitted sheet. They don't need any blankets, pillows, bumpers, anything like that. And we also don't recommend babies sleeping in things like a swing, a car seat, or like a DockATot, things that aren't approved safe sleep environments. Now you will hear a lot of things about sleep. If you read any type of, mommy blogs or Facebook groups or anything like that. So in general, I just like to review these terms. So co-sleeping is kind of an overarching term that basically means baby and mom or baby and parents sleeping in close physical proximity so they can tell that each other is nearby. And so this is an overarching term and kind of encompasses both room sharing and bed sharing. So room sharing is actually basically where the parents, like this picture, have the crib or the bassinet in the room with them next to the bed. So it's easy to feed and to establish breastfeeding, but baby always has their own environment to be put back into. And this is recommended by the American Academy of Pediatrics for the first 6 months of life to have baby actually in the room with the parents. Bed sharing is different. So that means baby would be in the bed. And this is something that we do not recommend. We do not recommend bed sharing in this at all. And then contact napping can mean a lot of different things, but you know, babies sleeping on parents on their chest and stuff during the day. In general, I say if parents are awake and alert and able to keep baby on their chest, it's okay for them to nap on their chest in those situations. But if parents get tired or anything like that, then it's recommended that baby goes in their own sleep environment. Now, in terms of SIDS and sudden unexpected infant death, this is something that we never want to see, never want to really talk about, but it's really important. So this is the sudden unexplained death of a baby younger than 1 year old, includes SIDS, accidental suffocation, and other deaths of unknown causes in the first year of life. But one of the benefits of breastfeeding is actually a pretty significant reduction in the risk of SIDS, so as much as 60%. And so that's really a huge benefit and something that cannot go overlooked. Other protective factors for baby is a safe sleep environment, like we talked about. Using a pacifier is actually a protective factor for babies once breastfeeding is established. Having a smoke-free home can be protective. Putting baby to sleep on their back. And then routine vaccinations have actually been shown to be protective against SIDS as well. And then making sure that you're avoiding weighted swaddles or any blankets or anything that have weight to them. This can actually be dangerous to the baby as well. So now that you got baby home, you got them through their first few nights, the next step is to bring them to the first pediatrician visit. So this is in general kind of determined by the providers in the hospital, how soon they want you to follow up. But in general, 1 to 3 days, we want to see them in the office for their first checkup. So try your best to arrive early. I recognize that it can be really hard with a new baby, but trying to plan ahead because it can be really hard to get out of the house the first time. Bring any paperwork that you have from the hospital with you, just in case your pediatrician needs to see it. The nurses will get the baby roomed. They'll get a naked weight so they can get an accurate weight, get a length and a head circumference, all those measurements, and they'll check a rectal temperature on baby. And then you'll see the pediatrician. And this first visit is really just a lot of what we call anticipatory guidance. So talking through normal feeds and pees and poops and all of those things, and maybe some jaundice, newborn rashes, lots of different things that we'll kind of talk about at this first visit. You're probably going to have lots of questions, and it's important to just write them down because being that you're probably going to be a little bit sleep deprived, keeping your questions handy can be helpful, and we're more than happy to answer all of those at the visits. If baby did not get hepatitis B in the hospital, we would in general recommend getting it at that first visit. And then if you are breastfeeding or even in the beginning with formula, we do recommend vitamin D supplementation for baby. So that would be 400 international units a day. And this is something that can be either bought over the counter or sent in as a prescription for baby. Now, in terms of frequency of feedings, in the beginning, you want to make sure that baby is feeding at least 8 times a day. So at least every 3 hours, but a lot of babies will feed more often than that, sometimes up to 12 times a day. And cluster feeding is something that definitely happens in the beginning where they're feeding more often. So sometimes even up to every hour they might be feeding. And this can actually be helpful in terms of bringing in mom's milk. Certainly it can be frustrating, but just know that this period of time where they're cluster feeding is not forever, but you do want to make sure that baby's getting at least those 8 feeds. With that, you want to make sure that you wake a baby. So you may have heard from, grandparents or things like that, never to wake a sleeping baby, but actually in the beginning, you do want to be waking the baby up, changing their diaper, getting them alert, and then trying to feed at least every 3 hours. You don't want them to go longer than that in the beginning while they're still gaining weight. We already talked a little bit about hunger cues, but looking for those hunger cues and learning what your baby does when they're hungry. In terms of amount, so again, it can be really difficult with breastfeeding to know how much they're getting, but you want to do about 15 to 20 minutes a day of, 15 to 20 minutes per side when you're breastfeeding, or about 1 to 2 ounces in a bottle at the beginning. Now, this will change as baby gets bigger, but this is in general my recommendation in the beginning to ensure that baby's getting enough. And then you always want to, if you're planning to breastfeed and then supplement, you always want to offer the breast first. And as often as you can, practice makes perfect with breastfeeding. So offer the breast first, and then if you need to, follow with pumping or giving the baby a bottle. Now, it can be hard to know exactly how much baby needs. So in the beginning, day 1, day 2, the baby stomach is very small. So it's only about the size of a marble, and they only need about even a half an ounce. So all of that good colostrum that they're getting in the hospital, they may not need a full ounce to 2 ounce, a full bottle. They really only need a little bit in the beginning. But their stomach grows quickly. So by day 3, it's the size of a walnut, or about an ounce, or 30 mLs. And then by day 10, it's the size of a golf ball, or about 2 ounces, or 60 mLs. And then this will kind of continue to grow as baby grows. So I think this helps kind of give you an idea of about how much they need. Now, voids and stools, or pee diapers and poopy diapers, these are things that we love to talk about as pediatricians. So in general, when baby goes home from the hospital, we would expect them to urinate about the same number of times as days old they are. So if they're 4 days old, we expect about 4 wet diapers in a 24-hour period, up to day 8. And then it's kind of a free-for-all. In terms of poopy diapers, we want to see the stools transitioning from dark, tarry, sticky stools. We call that meconium. That's probably what you'll see in the hospital. And then normal breastfed baby poop is kind of yellow, seedy in color, mustardy, and pretty loose. It's not going to be really formed stool at all. Then formula fed babies will they can have a wide range of stools. So it can be a little bit more formed. It can be a little bit more green in color. And all of that is normal for formula fed babies as well. And then a lot of families find it helpful to use a tracker application. So something like Baby Tracker, there's lots of different apps out there. This can be helpful for keeping track of how often you're feeding, and how many pees and poops and all those things. But I definitely have parents who use the analog way and write it all down too, and that's totally fine. So jaundice is something that is normal after birth. All babies have a little bit of jaundice. Jaundice is basically yellowing of the skin or the whites of the eyes. It usually happens within the first 48 hours, and that is usually gone by about 2 weeks of life. This is something that we monitor routinely in the hospital. We can either check it through the skin, through what we call a transcutaneous bilirubin, or we can check it in the blood, or what is a serum bilirubin. And the blood is always going to be more accurate. Breastfeeding babies are typically a little bit more jaundiced, just because it takes a little bit more time for mom's milk to come in. They may not be peeing and pooping as much, which is how they get rid of the bilirubin in their pees and poops. So all of these predispose them to being a little bit more jaundiced. And then there may be individual factors that are at play in terms of why a baby may or may not be a little bit more jaundiced. And that's something you can talk with your pediatrician about. Very rarely we need to do treatment, but it is possible that this might be something in the hospital or after you go home from the hospital that might be needed. The treatment for jaundice is called phototherapy. It's basically blue lights that help get rid of that bilirubin that's built up and get rid of it more easily in the pees and poops. So that's the treatment, and that's something that your doctor will talk about if needed. Now, caring for the umbilical cord. So the umbilical cord usually falls off around day 5 to 15. Really, the biggest rule is just to keep it dry and not to mess with it. It will fall off on its own. It may be a little bit stinky as it's falling off, and that's normal. When the baby's first born, it's really soft and gelatinous. You can actually see the blood vessels running through it, and then it will kind of get hard and more crusted and change color, become a little more brown, and then fall off. A little bit of bleeding around it when it falls off can be normal, but if there's what seems excessive, I would just talk to your pediatrician, and sometimes we can do something called silver nitrate and help with that bleeding. Babies that are circumcised, so just so you guys know, circumcision is an elective procedure. There are risks and benefits as with any procedure, and this is something you'll talk about in the hospital. But usually it's performed in the birth hospital. Most pediatricians don't do these in the office anymore, although that might be different depending on your pediatrician. After the baby is circumcised, though, you want to make sure that you keep the area clean, just with warm water. You want to kind of avoid a lot of diaper wipes that have a lot of chemicals in them. it is going to look a little bit swollen, a little bit red. There may even be a little bit of like discharge around the head of the penis there, and that's normal. That's normal healing process for a circumcision. And then in general, you want to use Vaseline with every diaper change, a fair amount, to be generous with that. And then you can put a piece of gauze on the top if you would like, but you don't always need to do that. And then it can take a full like 7 to 10 days to heal fully from the circumcision. Now, crying and colic, this is a huge topic that we talk about all the time in the office, but I really like to set the expectation that when baby is born, it really is the 4th trimester. Baby is used to being inside you, being warm, being snuggled up, hearing your heartbeat, all of those things they still want after they're born. And so trying to create those environments as much as possible can be really helpful in easing the transition for baby. The other thing I like to say is that babies cry in order to communicate their needs. They can't talk or communicate their needs in other ways, so they need to cry. And so that can be an indicator that there's something going on and that they are either hungry or need a diaper change or uncomfortable. Lots of different reasons why they cry. Now, colic is what we consider a little bit more than normal crying. So this is crying for more than 3 hours a day on 3 days a week. So it's actually quite a bit. Most babies don't meet the criteria for colic. Colicky babies, usually they're crying around the same time of day, each day, usually in the early evenings. It can be hard to soothe them during these episodes. And this usually starts in the first few weeks of age and can last several months for some babies. So I always talk about the 5 S's for soothing the baby. So swaddling the baby can be super helpful in the beginning, helping them feel tucked in and secure. Sometimes putting them on their stomach or on their side when they're being supervised, that can be helpful. Shushing them, doing little backpack pats on the back, swinging them back and forth, either in a swing or just with them, carrying them around, and then sucking or using a pacifier can be soothing to the baby. And then I always like to remind parents that it's important to know your limits. Having crying babies and being sleep deprived can be really overwhelming. And so if you are feeling overwhelmed or you're feeling like you just wish the baby would stop crying, it's always important to just put the baby back in their sleep environment and take a break or get your partner to help out. Now, there's tons of common breastfeeding questions, and some of you may have specific questions that we can talk about, but some of the common things I talk about in my lactation visits are the size of the flange, which is the piece that goes over the nipple on the breast pump, using nipple shields, which are something that we sometimes use over the nipple to help the baby latch, using pacifiers, whether I would recommend it or not, clogged ducts, engorgement, increasing your milk supply and how to do that, and then thrush. These are all things I talk about all the time, and I'm happy to answer questions about if you have specific questions. Now, the transition out of, from maternity leave in the newborn period and then going back to work can be a huge one. So in terms of how often to pump, if this is something that you desire to do, it really depends on what your individual goals and needs are. So some parents, I would recommend that the baby is struggling with weight gain and we may need them to pump like every 3 hours in order to give them a supplement. So that's something that is sometimes indicated. Some moms choose not to pump at all and they just feed the baby at the breast and they do great. Some moms will pump exclusively and give all of the breast milk by bottles, and that's okay. Some will pump so the partner can help out and give bottles so mom can get some rest. Some families will choose to pump to help build up their supply so they can go back to work and will have a breast supply. Some moms will power pump once a day to help increase their supply, which is something we can talk about if there's questions, but there's really no one size fits all when it comes to your schedule for pumping. But this is something that is really individualized to each family. Now, in terms of storing milk, there's lots of different rules, but this chart kind of lays out how long it can stay in the fridge or the freezer or out. And you guys will get all these slides. So this is a helpful thing to keep in mind. Now, for moms going back to work, in general, we recommend pumping every 3 to 4 hours at least to maintain your milk supply. Now, this is different for every mom, but in general, that's my recommendation. In Michigan, there's currently no state laws regarding breastfeeding, but mothers in Michigan are protected under the Federal Fair Labor Standards Act. So this entitles moms to a reasonable break time and a private space other than a bathroom to pump at work. This is for up to a year after the child is born. However, employers are not required to pay employees for these break times. And there is an exception for employers that have 50 or less employees. So there are some loopholes that can make this difficult. But, always talk to your doctor or your pediatrician, and they may be able to provide a note to ensure that you're able to pump at work. There's lots of different laws around breastfeeding. So paid maternity leave is a big one, and how long that, mothers get for paid maternity leave, and fathers, which in this country is not the best, I will be honest with you. In a lot of other countries, they're doing a lot better in terms of these laws. In Michigan, women are protected from indecent exposure. So women should be able to nurse in public and in private. Women in Michigan are actually exempt with a doctor's note from jury duty, and if they're breastfeeding, and then businesses are not allowed to discriminate against nursing mothers or tell them to stop nursing in public. Now, in terms of continuing to breastfeed, there's lots of considerations. Again, these are things that we can talk about if you guys have questions, but teething infant, sleep regressions, distracted eaters as they get older, introducing solid foods at 6 months and how to do that with breastfeeding, and toddlers nursing. All of this kind of has its own set of things, and we won't get into all of these, but these are all other considerations as well. And then I did just want to briefly touch on the AAP, or the American Academy of Pediatrics, that oversees all pediatricians. They actually just updated their policy statement, and it was published in the July Journal of Pediatrics. So the American Academy of Pediatrics recommends exclusive breastfeeding for the first 6 months of life. And then they support continued breastfeeding along with complementary foods introduced around 6 months for as long as desired, up to 2 years. And so 2 years and beyond is the part of the policy that is new. So it used to say 1 year, but 2 years actually aligns more closely with the World Health Organization and what other countries around the world are recommending. And the reason behind this is that there actually have been shown to be health benefits, particularly for mom, in terms of reducing cancer risk for those who breastfeed longer than a year. So that's part of the reason that this was changed. There's also some information in the new policy about supporting gender diverse families, families, that, parents may want to be breastfeeding, or something we may call chest feeding. And so that's something else that's talked about in the policy. And then it talks about the different policies and laws in this country and how we can best support them as pediatricians. So I just want to say real quickly, and then we'll get to questions. So there's lots of support within IHA, St. Joe's, St. Mary's. We want to make sure that you guys, if breastfeeding is something that you want to do, that you have the support that you need. So we actually have a whole division within IHA called the Breastfeeding Medicine Division. This is led by Dr. Lisa Hammer and Dr. Catherine Langton, and they have a whole team of nurses and nurse practitioners that can help with lactation. There's also several nurse practitioners in the offices, as well as myself at Livonia Schoolcraft campus. And they're definitely more than willing to help with breastfeeding questions, helping baby latch, and doing some lactation in the office as well for their patients. So we're here if you need us. And now we'll get to some questions.
Awesome. Thank you so much, Dr. Nash. That was a great presentation. Tons of amazing information.
Yeah.
Okay, so we do have a handful of questions here, so I will pull them up and we'll get going down the list.
Yeah.
So the first one, she's asking, do you recommend colostrum harvesting and freezing before birth?
Sure. That's a good question. So, and I can just like answer right here. I don't have to type or anything. Is that right?
Absolutely. Yeah,
Okay.
go for it.
Okay. So yeah, I mean, so colostrum, so not every mom is going to start producing colostrum before baby is born, but if you do, I think saving every little bit of breast milk that you can, and if you're able to hand express some of that early colostrum and save it and freeze it, I think that's great, and that offers those additional antibodies and everything for baby. So so if you are able to hand express or to produce a little bit of colostrum before, then that's definitely something that I would support and think it's great for baby.
Great. So do milk ducts and hormones cause some moms to have a low milk supply? And if she does have a low milk supply, what do you suggest?
Yeah. So, so hormones definitely play a role, and the breast tissue itself. So like I talked about, if there had been any surgeries, that disrupt the architecture of the milk ducts and the milk producing cells. So, those definitely can affect the amount of milk that mom produces. So, so that's why it's important to get a history about, does mom have these surgeries and things like that. And then the hormones definitely can affect milk production as well. So if there is, for example, retained placenta, so not all of the placenta leaves after baby's born, this is something the OBs typically deal with. But in terms of breastfeeding, that can mean that though you don't get those drops in estrogen and progesterone after birth, and then it can be difficult for the milk supply to come in. So that's why it's really important to make sure all of the placenta is out from a breastfeeding perspective, because then the milk may not come in from that standpoint. So, and also, like I talked about, stress can definitely impact milk letdown, and relaxation and comfort and being close to baby can help with milk letdown. So all of these things are really complex systems, and there's lots of things at play, but yeah, there definitely can be disruptions to both the hormones and the anatomy of the breast tissue. Hopefully that answered your question,
Yeah,
Julia.
definitely. And it sounds like there's really no right answer if you find those challenges. It's kind of like every family can work through it the way that works best for them.
Yep.
So if it's a combination of formula and breast milk or things along those lines, they can.
Yeah. Oh, yeah. So yeah, if mom has a low milk supply, there are lots of things we can do. Oftentimes the signal to the breast to make more milk is an empty breast. So feeding baby frequently and pumping frequently are usually my first go-tos in terms of how to increase supply. Sometimes we do something called power pumping, where moms pump more frequently, and that can help increase their supply as well. And then there are, the data is kind of mixed on if there's different foods or different things you can eat. But in general, I say to stay hydrated and well fed, and then some of those other things, I would talk with your doctor about before trying to increase your supply.
Excellent. So if you are breastfeeding, does pumping affect the supply of milk in a negative way, or is it mostly positive?
So that's a good question. So for the most part, pumping will affect in a positive way. It will help, especially in the beginning, it can help bring your supply in. Now, the problem becomes if you tend to be like an oversupply person or someone who's producing too much and you're pumping too much and you get more engorged, that can actually signal decreased production. So that's kind of the balance. So in general, I would say pumping, especially in the beginning, is going to help your milk come in, and it's going to help with the breastfeeding journey. But if you pump too much, then you can end up with the opposite problem. So but that's a really good question, and hopefully I answered that as clearly as I can.
Yeah, definitely. And how about switching from side to side? So should you be pumping or breastfeeding from both sides each session?
So in general, I do recommend trying to feed baby on both sides. Now that may not happen every time because they may fall asleep or have trouble latching on the other side. But in general, it's good to feed from both sides. Now, when I'm working with parents, I usually say the first side's dinner, the second side's dessert. And so they may go for 15 minutes on one side and only 5 minutes on the other. And then that's okay. But in general, I do recommend feeding from both sides each feed as much as possible.
Great. So how do you know when it's maybe time to start supplementing with formula, that maybe your baby is not getting enough breast milk?
Yeah. So in general, this will be something that's kind of decided with your pediatrician within those first few visits, but we want to make sure that baby is gaining enough weight. So, or not losing. So I didn't really talk about this, but it is normal for baby to lose weight after they're born. So we expect that. We know that's going to happen. This happens for lots of reasons. You know, babies get rid of lots of fluids from their kidneys and things like that. But we expect up to 10% of their body weight to be lost in those first, week of life. However, we want to see them heading in the right direction, starting to gain weight and getting back to their birth weight by 2 weeks. If we're not seeing that weight gain and they're continuing to lose weight beyond that 10%, that's when we start to get more concerned and we may need a supplement in those situations. So that's something that you and your doctor will decide on. And I always tell parents too, even though they may need a supplement in the beginning, this doesn't mean that you are not going to be successful at breastfeeding. It may just mean that in the beginning, we need to get baby a little more alert and feeding a little bit more, help get rid of some of that jaundice and get them more active so that they can breastfeed better. So I want to make sure that, I think a lot of families and parents get discouraged if you have to supplement, but sometimes this is just, the step we need to take to make sure that baby's getting back on the right track and gaining good weight.
Okay, so we have someone who it sounds like they are supplementing. And they're also pumping every 2 hours, but their milk supply doesn't seem to be increasing. Do you have any suggestions?
Yeah. So, so that can be, it depends on lots of things. So, I don't want to, there are some situations here where I may not be able to help fully because, I'm not seeing you and looking at the whole global picture. But if you're pumping every 2 hours and you're still struggling with milk production, that's a time that we may want to look into doing some power pumping to increase your supply. We may want to look at, is baby actually latching well when they do feed, and it is also true that if you're exclusively pumping, there are some times and some people that struggle with keeping their supply up just because the pump is not quite the same as the baby triggering that milk reflex. So again, I know that's probably not a great answer, but I would talk to your doctor or talk to a lactation specialist to see if they can maybe help you with some of those specific questions in terms of increasing your supply. Now, there are rare occasions that we use medications to help increase supply, and this is another option too. So that's something that you could talk to your OB about as well.
Okay, great. So what about, I know kind of when you're, at least for me, when I had my first child, you hear people talk about pump and dump. So you can have an alcoholic beverage while you're breastfeeding. Yeah. Is that a real thing?
Yeah, so that's a good question. So in general, we actually don't recommend pumping and dumping anymore. That those recommendations have kind of changed. So in terms of using alcohol, so we do allow up to one alcoholic drink, so one standard size drink. And in general, the amount that baby would get exposed to 3 hours afterwards would not be enough that we would want them to dump out that milk or not breastfeed the baby. So in general, we want to see at least a 3-hour time for mom to metabolize the alcohol before they feed the baby. But it is okay if they want to have like one standard drink. But we do discourage heavy drinking because that can impair mom's ability to breastfeed and stay awake and things like that. But it is okay to have one standard drink and then feed the baby at the 3-hour mark afterwards.
Okay, excellent. So we have one last question about pumping, and then we'll move on to some sleep questions.
Sure.
So is there anything that can be done? So we have someone who's pregnant and it sounds like she's going to deliver in just a couple weeks. So anything that can be done in these final weeks to get a smoother start for breastfeeding? Yeah.
So there's lots of things I would, work on kind of just practicing hand expression. So that's something that you can get used to kind of, and you may even be able to express some colostrum as we talked about. So, practicing hand expression, making sure that you read a little bit about breastfeeding, that you kind of, know a little bit about what to look for in baby cues and things like that, being a part of this presentation is a great step to learning a little bit more about breastfeeding. But honestly, most of it is going to be kind of a whirlwind when baby comes out, and learning kind of that process. But I would say, you know, getting comfortable with the, you know, all the idea of breastfeeding, making sure you have all the supplies in place, your pump ready, you know, all of those kind of things, I think is the best thing that you can do. And then just, you know, practicing some hand expression in the beginning.
Awesome. So we'll move on to a couple of sleep questions.
Yeah.
So we have when your baby comes out, obviously they have their umbilical cord. Is there anything you suggest in terms of pajamas? Because a lot of the newborn pajamas, or you know, they have the zippers. Is that something that is safe for them with the umbilical cord, or should you take something else?
Yeah. So in general, they can be, you know, in normal onesies or you know, pajamas. In general, I usually just say to make sure it's kind of loose fitting, so it's not tight against the baby's skin where the umbilical cord may rub. And I usually tell parents to fold the diaper down, so that's also not rubbing on the umbilical cord. But really, I just say, you know, most of their clothes are going to be pretty big on them anyway at this stage. So, so usually that's all fine. Yeah, that's a good question.
Yeah. So someone is also asking if they can put a light blanket on their child at night, or newborn.
Sure. So in general, we don't recommend any blankets, pillows, anything in the crib with the baby, and they really don't need it. So I always tell parents that I recommend keeping the temperature of the house between 68 and 72 degrees if you have a newborn. And then in terms of baby, if they have a onesie on and a swaddle or a sleep sack, that should keep them warm enough throughout the night, so they don't actually need an extra blanket, and that can be a risk factor for suffocation and SID. So we don't recommend any additional blankets in the crib with them.
Excellent. And then how about kind of prepping for trying to make or get your baby fuller at night? Is there anything you can do feeding just before bedtime that might help them sleep a little longer?
Yeah. So in the beginning, it's going to be hard because we still want you waking them up to feed often, but you know, a lot of babies will cluster feed kind of in the evening hours. So so kind of the biggest thing I tell parents is to follow their cues, and then doing a good feed before you put them down for that last bedtime. So either making sure that they breastfeed for a full session, or if they still seem hungry after that breastfeeding session, you can give them a little bit of express breast milk or formula or something to keep them a little bit fuller longer. But in the beginning, in general, we still want you to be waking up baby at least at the 3-hour mark. Now, in general, my rule, and everyone may have a different rule, but I usually say once they're 10 pounds or above, that's when you can start to space out a little bit longer and between feeds at nighttime. But in the beginning, you know, I would just continue to feed kind of on demand and follow your baby's cues for when they're hungry.
Great. And so it sounds like if you have that sleep environment in your bedroom or where you're sleeping, it might make it a little bit easier to get to the baby. So someone's actually asking, how common is it for room sharing to continue through 6 months? Are you seeing that with a lot of your patients?
Yeah, that's a good question. I mean, I think every family has their own, you know, unique experiences. I would say a lot of my patients do stay until 6 months and then transition to a crib in their own room. I have some families that do choose to move the baby out of the crib, you know, around 4 months. And I have some families that choose to keep the baby in the room until a year. So it's really individual, but I think it's definitely, on average, I would say most families will move the baby into their own room around 4 to 6 months.
Okay, perfect. So we have a couple questions around making appointments and getting into see your pediatrician for those first appointments. So are you able to make the appointment before the baby is born? Is that a possibility?
So you're not, unfortunately. So in general, we just recommend when you're in the hospital with the baby to call and schedule that first appointment, just because lots of things can happen. Labor can take a long time and you may miss the appointment. So so in general, we recommend when you know your discharge date, then we would recommend calling the pediatrician and scheduling that first visit.
Excellent. And does one of the parents have to call, or is that something like a grandparent could pick up for a tired mom?
That's a good question. I'm not 100% sure. Probably our reception staff would know better than
Yeah.
me, but I think probably a grandparent could call on behalf, but they're probably going to ask for like insurance information and specifics and stuff. So it probably is better if one of the parents can do it, but I'm sure if they gave permission, it probably could help if the grandparents called too.
Excellent. So for any kind of breastfeeding support, your pediatrician, how readily available are those appointments? Do they make room in the schedule to make sure that the new moms and dads can get in?
Yeah, that's a great question. So, well, in the hospital, there's lactation consultants there 24/7. So, there's, always going to be someone on call if you need help. And then also the nurses are very skilled at lactation. So, so in the hospital, there should be someone there if you have questions. Now, obviously during the daytime hours, there's going to be a little bit more readily available for you in the hospital. Now, in terms of appointments, in general, through IHA, we're able to get people in fairly quickly for these appointments. Sometimes it can be, 5 days to 7 days for the breastfeeding medicine specialists. And that's usually where I'll send babies that are like, I'm really struggling with it myself. So a little more complex cases, NICU babies, things like that. But like I said, there's me at my office, and then in several of the pediatric offices around here, there's nurse practitioners that will see babies. And usually we can get you guys in pretty quickly. And in general, I see about 2 to 3 lactation visits on average a day. So there's definitely appointments available if that's something you guys are interested in.
Awesome. So we just have a couple more questions. Are you good to stay on for a
Yeah.
few minutes?
Yeah,
Great.
no problem.
So when your milk first comes in, do you have any recommendations for helping to relieve some of that discomfort?
Yeah, that's a great question. So it can be very uncomfortable in the beginning. So the biggest thing I recommend is to continue to try to feed baby, because emptying the breast and getting rid of that engorgement can be helpful. So either pumping or putting baby to breast regularly. You can also do either hot or cold packs, things to help reduce the inflammation and whatever feels good. If you're really engorged and really swollen, it can be hard for the baby to latch. So sometimes we would recommend something called reverse pressure softening. So basically where mom is lying on her back and she's slowly compressing from the nipple outwards, so backwards away from where the milk comes in, to kind of get rid of some of that swelling and lymphatic tissue. So that's something that that a lactation consultant can show you. But in general, when your milk starts coming in, the best thing you can do is to start feeding. If you're really engorged, going in the shower and where you can be relaxed and warm and doing some hand expression just to kind of get rid of that extra milk. I know it seems sad, but in the beginning, if you're really, really sore, you want to try to relieve that pressure. You can definitely go in the either in the shower or put your breast in some warm water and hand express and get rid of some of that extra milk that came in.
Okay, excellent. And how soon after your birth should you start to try to get a bedtime routine going for baby? So,
yeah,
7 p.m. is bedtime, and maybe read a book and things like that. How do you recommend starting?
So that's a great question. So in general, I am a big proponent of kids and babies and infants and newborns responding very well to routine. So I'm a big proponent of that in all families. So even starting from the first few weeks of life, I think, trying to set a bedtime that's consistent. Usually in the beginning, the bedtime will be a little bit later. So 9, 10 o'clock, usually when parents are, hoping to lay down for a little bit, but pick a time and do the same thing every night. So do bath time and change diaper and read a book and listen to, or play some music and try to get in the same routine every time. I don't think it's ever too early to start doing a bedtime routine. And babies' circadian rhythms, or their sleep cycles kind of respond to these routines. So I usually say if they have their days and nights mixed up, if they're up all night and sleeping during the day to bring them out in the main part of the house, open the windows, have natural light, normal sounds, and then trying to keep things dark and quiet at nighttime. All of those things can kind of help baby set their routine. Now, in terms of sleep training and letting baby cry to sleep and those kind of things, usually I don't recommend those things until about 4 months of age. But definitely having a bedtime routine and is a great thing to start even from the beginning.
Awesome. And I found it was helpful for the parents too.
Yeah.
That is learning one.
Yep.
So a couple questions about vaccines. So the first one is, when can a new mom get the flu shot?
Mm-hmm.
And
Good
then
question.
the second one is, if a mom has been vaccinated for, let's say, COVID-19, is that helpful to the newborn in any way until that 6-month period when they can start to get some of those other vaccinations?
Yeah, great question. So we would recommend getting the flu shot during pregnancy if it's flu season, or if it's not quite flu season, then, which is usually September to May in general. So if as soon as baby's born, then we would recommend mom getting the flu shot if it's, whenever flu season starts. So basically, whenever they can get it, we would recommend them getting the flu shot. COVID vaccine, same thing, really. There has been lots of studies that show that the COVID vaccine is safe during pregnancy and is recommended by the OBGYN groups. And babies do get antibodies from mom through the breast milk and through the placenta. And so there are protections against babies now, or protection for babies against COVID-19. Now, we don't really know exactly how great of protection or how long that protection lasts, but hopefully with COVID vaccines being approved 6 months and beyond, that moms getting that vaccine or having that protection during breastfeeding can be helpful to babies in the first 6 months of life.
Excellent. So we have one more question, and it's about twins. So this mom is wondering if there are any different or additional recommendations for moms of multiples in terms of breastfeeding.
Yeah, that's a great question. So twins can be tough. I have many twins in my practice, and it definitely can be tough to breastfeed for a lot of reasons. Some being that twins are a little bit smaller often, so it can be a little harder to establish the latch. And then producing enough milk to feed both babies can be challenging. That being said, most moms of twins can produce enough milk to feed both babies. And a lot of times, it depends, and I would work with a lactation consultant in the case of twins, because it can be difficult. But some moms will choose to do tandem feeding, so feeding babies at the same time, one on each breast, and then some will start with doing one at a time to help build in their milk supply, and then we'll switch to tandem feeding. But it's definitely possible. You may need some extra help and in terms of getting your supply up, and then there may be times where you need a supplement, but it's definitely possible, and it's something I would definitely recommend working with a lactation consultant on after the babies are born.
Awesome. And we actually have one more question come in. I'm going to ask, because it's about vaccines as well. So when should family members receive the DTaP vaccinations before seeing newborns?
Yeah, that's a great question. So in general, we recommend moms and all members of the family get their Tdap vaccine, or their diphtheria, tetanus, and pertussis vaccine, or whooping cough. We actually call that cocooning. So basically everyone around the baby has protection against those things, particularly the whooping cough or the pertussis. So in general, moms can get the Tdap during pregnancy, and most OBs will give the Tdap, but I would recommend that that other partners and other family members all get updated on their flu shot and their COVID shot and their pertussis vaccine before being around baby. That's something in general I would recommend to cocoon the baby and keep them safe from some of those diseases that can be really dangerous in the beginning of life.
Awesome. Well, thank you so much, Dr. Nash, for staying for all these questions.
Of course.
An amazing presentation. So you do see patients at the Schoolcraft pediatric location, and that's on the Schoolcraft campus, and you are accepting new patients. Okay, excellent.
Yes.
And so your contact information will be included in the email that we send out to all of the attendees. Perfect. So if you are interested in contacting Dr. Nash for an appointment when your baby arrives, you will have the information right there to do so.
Yeah,
so
perfect.
Thank you again so much. We really enjoyed the presentation. Thanks for
no problem. Yeah, I
Yeah.
saw a question about thrush and I can touch on it really quickly.
Oh, yeah,
Sorry.
absolutely. No, go ahead.
Sorry. So I just want to make sure. So thrush is basically a fungal overgrowth that can happen in baby's mouth, and it can also be spread back and forth between mom and baby, between the nipple and the mouth. So if your baby gets thrush or you're concerned about thrush, talking to your doctor, making sure that's what it is. Sometimes babies can get a white tongue after feeding. As if you can wipe it off easily, it's probably not thrush. But if it starts to spread to the cheeks or the top of the mouth, that can be an indicator that it's thrush. So in those cases, we do treat baby with an oral medicine to help with the thrush. And we also recommend mom treating the nipple area and then cleaning all pump parts and everything and sanitizing so that thrush isn't continue to be spread back and forth. It's usually not painful if baby has thrush, unless we let it go a long time without treating it. And that in those cases, sometimes the thrush can get even down into their esophagus and things like that. And that can start to be painful. But in the beginning, if it's just on their tongue, it's usually not super painful. That's a good question.
Excellent. Thanks for
Yeah.
noticing that and answering it for us.
Yeah, no problem.
All right. Well, we do appreciate you. Thank you so much. This is amazing. And we appreciate all of you for joining us tonight. So look for that.
Yeah,
email
thank you
tomorrow.
guys so much. I hope this was helpful, and let me know if there's ever anything I can do to help. Okay, have a good night.
Excellent. Thanks, Dr. Nash.
Yep.